Bismillahirrahmanirrahim. Nahmaduhu wa nusalli ala rasulihil kareem. My name is Dr. Imran Rasheed Ahmad. I am professor and head of the Department of Pediatrics, Dow International Medical College. Assalamu alaikum. Today we are going to discuss a very important topic, which is acute rheumatic fever. Next slide. The learning objectives. ये इसकी स्लाइड जो है ना, ये इसको ऐसे करें कि मुझे स्लाइड पढ़ने में तो आए. इसकी पोजीशन को टॉप पे 25% पे करें. हाँ ये अब सही. Sorry for this inconvenience. The learning objectives of today's lecture is that at the end of the lecture, the student should be able to know the epidemiology of acute rheumatic fever. And second, the student should be able to identify the clinical features of the disease. And third, the patient should be able to, the student should be able to enumerate the laboratory findings in a patient with rheumatic fever. And the student should know the steps of treatment of rheumatic fever. Now, acute rheumatic fever, it's a systemic disease of childhood, often recurrent, that follows group A beta hemolytic streptococcal infection. So this is a disease caused by group A beta hemolytic streptococcal infection. It's a delayed non-suppurative sequelae to upper respiratory tract infection with group A beta hemolytic streptococci. So first of all, the group A beta hemolytic streptococci affects the tonsils and the pharynx, cause tonsillopharyngitis. And after a week or 2 weeks or 3 weeks, there is an immune response that takes place. And that same immune response not only causes damage, it causes damage to the different portions of the body. So it's a diffuse inflammatory disease of connective tissue, primarily involving the heart, blood vessels, joints, subcutaneous tissue, and CNS. Now the epidemiology. The age is 5 to 15 years. That is the most susceptible age for getting this disease, rheumatic fever, is 5 to 15 years. That is school going age. In this age group, the students are going to the school and they are contracting this pharyngitis secondary to group A beta hemolytic streptococci because of the overcrowding there. And then this disease results as a sequelae of this streptococcal pharyngitis. It's rare below the 3 years of age, and it is seen that the rheumatic fever is slightly more common in girls as compared to the boys. And it's common in third world countries, that is developing countries. And the environmental factors that are related with this disease are the overcrowding, poor sanitation, and poverty. Because of overcrowding, if someone is suffering from this disease, he can transfer the same bacteria to the nearby person. Similarly, poor sanitation, poverty are the other reasons where even if the patient develops this, he doesn't get proper treatment and he doesn't have enough funds to go to the doctor and take the proper medication, and that results in partial treatment of that streptococcal pharyngitis, and that as a sequelae to that, the child develops rheumatic fever. Incidence is more during fall, winter, and early spring. Now let's discuss about the pathogenesis, that how this disease happens. It's a delayed immune response to infection with group A beta hemolytic streptococci. So it's a delayed immune response to infection with group A beta hemolytic streptococci. So there are certain antigens that are present on the wall of this group A beta hemolytic streptococci. The immune system develops antibodies against those antigens, and similar sort of antigens are present in the other parts of the body. So those antibodies that are produced against those bacteria, they also affect those antigens that are just like those antigens that are present on the bacteria. They are also present in different parts of the body, so they also strike those parts and destroy them. So after a latent period of 1 to 3 weeks, antibody induced immunological damage occur to the heart valves, joints, subcutaneous tissue, and basal ganglia of the brain, because it has been seen that the same antigenic structure is present in these parts of the body as it is present on the bacterial cell wall. So those antibodies that are created against that bacteria damages these tissue as well. So this is the pathogenesis of this disease, rheumatic fever. Now, the group A beta hemolytic streptococci, there are strains that produce rheumatic fever. M type 1, 3, 5, 6, 18, and 24. These are the serotypes that results in rheumatic fever. Pharyngitis produced by group A beta hemolytic streptococci can lead to acute rheumatic fever, rheumatic heart disease, and post-streptococcal glomerulonephritis, meaning that those strains of group A beta hemolytic streptococci that results in pharyngitis that may result in later on acute rheumatic fever, rheumatic heart disease, or post-streptococcal glomerulonephritis. But those strains of group A beta hemolytic streptococci, those causes skin infection, they only results in post-streptococcal glomerulonephritis. So skin infection produced by group A beta hemolytic streptococci leads to post-streptococcal glomerulonephritis only. It will not result in rheumatic fever or carditis, as skin lipid cholesterol inhibit antigenicity. So to simplify it, there are certain strains of group A beta hemolytic streptococci that causes pharyngitis. Those strains may cause not only acute rheumatic fever, rheumatic heart disease, and post-streptococcal glomerulonephritis, but those strains that only that affects the skin, they have the potential to only cause post-streptococcal glomerulonephritis. They don't cause rheumatic fever or rheumatic heart disease. Now the clinical features. Arthritis is the first clinical feature. It's a flitting and fleeting migratory polyarthritis involving major joints. Flitting and fleeting migratory polyarthritis involving major joints. The patient complains that, sir, I have first of all pain in my right knee joint, and that lasted for 2 to 3 days, and when it starts decreasing and the pain gets settled gradually, I noticed that now my left ankle joint has started developing swelling, redness, tenderness, and after a few days when it settled, I found that my right elbow joint has started getting swollen, red, tender. So this type of migratory type of polyarthritis, where one joint is affected first and then it got better and then another joint get affected, this sort of polyarthritis, which is called migratory polyarthritis, that is very typical of rheumatic fever. So the first presentation of arthritis is that the patients with this disease have flitting and fleeting migratory polyarthritis involving major joints like knee joints, ankle joint, elbow joint, wrist joint, etc. And it occur in 80% of occur in 80% involved joints are exquisitely tender. They are very tender to touch. So one of the hallmark of this disease of rheumatic fever arthritis is that this is exquisitely tender. Even just touching the cloth of the bed sheet can result in severe tenderness. So that is very typical of rheumatic fever arthritis. In children below 5 years, arthritis usually mild, but carditis is more prominent. So if someone develops rheumatic fever under the age of 5 years, the arthritis will be mild, but carditis will be more prominent. But if a child develops after the age of 5 years, then the chances are that the chances of carditis will be less and arthritis will be more. So in children below 5 years, arthritis usually mild, but carditis is more prominent feature under the age of 5 years. Arthritis do not progress to chronic disease. That is the main thing regarding the rheumatic fever arthritis, that it doesn't lead to chronic disease of the joints. So the joint that is once affected for few days, after few days that joint will be perfectly all right, and there will be no residual damage in that joint, and that joint will work perfectly. So there is no progress to the chronic disease as we see in patients with rheumatoid arthritis, where gradually the joints get destroyed. But in rheumatic fever, although it causes severe arthritis, but it is only transient for few days, and after that there are no sequelae to that, there is no chronic disease. That is why this disease, rheumatic fever, is considered as told like this, that it is a disease that licks the joints but bites the heart, meaning that it just touches the joints, but actually it damages the heart. And the main problem of rheumatic fever is this, the after effect, that it causes permanent damage to some children with rheumatic fever in the valves of, and the heart gets affected on the long-term basis. So basically, although the arthritis is very severe, but it is transient and it does not progress to chronic disease. Now, the second clinical feature after the arthritis is carditis. It manifests as pancarditis, meaning it affects the endocarditis, myocarditis, and pericarditis. So, all the three layers of the heart, endocardium, myocardium, and pericardium, inflammation of all these three layers takes place in patients with rheumatic fever. That is called pancarditis. So the carditis manifests as pancarditis, and it occur in 40 to 50% of cases of rheumatic fever. One see carditis. Carditis is the only manifestation of rheumatic fever that leaves a sequelae and permanent damage to the organ. So this is the most important complication of rheumatic fever, because this is the only manifestation that leaves a sequelae and permanent damage to the organ. Otherwise, arthritis and the other clinical feature that we will be discussing, they are just transient. They are not going to affect permanently. The only feature that affects permanently is the heart, that gets affected in patients with rheumatic fever. Valvulitis occur in acute phase. In acute phases, there is inflammation of the mitral valves most commonly, and then the aortic valves. In the chronic phase, the fibrosis, calcification, and stenosis of heart valves take place. Now, the third clinical feature of rheumatic fever, first was arthritis, second was carditis, and the third is Sydenham's chorea. It occurs in 5 to 10% of cases, mainly in girls of, you should correct it, it's 10 to 15 years of age, not 1 to 15 years of age. It's a typographical mistake. It's mainly in the girls of 10 to 15 years age group. It may appear even 6 months after the acute of attack of rheumatic fever. So one might have forgotten that might be that patient has had some sore throat 6 months back, and the patient just comes to you with the Sydenham's chorea with involuntary movements taking place. And when you ask the patient, do you have a history of sore throat few weeks back, and they don't recall it, because Sydenham's chorea can occur even after 6 months of the attack of sore throat or rheumatic fever. Clinically, it manifests as clumsiness, deterioration of handwriting, emotional lability, or grimacing of face. So usually the mother of the child complain that he is breaking the most of the glasses, uh, that are used for drinking purpose, they broke because of the clumsiness. And the school teacher complained that the handwriting of this child has deteriorated over a few weeks' time. Otherwise, this child's handwriting was exceptionally good. But now I am noticing that your child's handwriting is deteriorating. And other friends also feel that the child's emotionally has become very labile. On slight provocation, the baby or the child starts crying, and emotionally he is not stable. And often on these sort of children do get ridiculed from the teacher as well, in the form, in the complaint that the child is grimacing to the teacher, making facial impressions. Actually, he is not intentionally making the facial impression to tease the teacher. It's happening with the child. So the clinical manifestations are clumsiness, deterioration of handwriting, emotional lability, or grimacing of face. Now, in the clinical features, after the arthritis, carditis, Sydenham's chorea, the fourth clinical feature of rheumatic fever is erythema marginatum. It occurs in less than 5% of patients. It's a unique transient lesions of 1 to 2 inches in size, pale center with red irregular margins, more on trunks and limbs, and non-itchy. And it worsens with application of heat. And it is often associated with chronic carditis. So it is seen in only less than 5% of patients, and it is a non-itchy sort of rash where there is pale center and red irregular margins. And if you find erythema marginatum in a child with rheumatic fever, you can anticipate that in the future this child is going to have chronic carditis, because it has been seen that those children who develop erythema marginatum, it is often associated with chronic carditis. Now, the fifth major clinical feature of rheumatic fever, beside the arthritis, carditis, Sydenham's chorea, erythema marginatum, is fifth one is subcutaneous nodules. They occur in 10% of patients of rheumatic fever. It's a painless, pea-sized, palpable nodules, and they are mainly present over extensor surfaces of joints, spine, scapulae, and scalp. And they are associated with strong seropositivity, meaning that ASO titer, anti-streptococcus O titer, will be markedly increased in those children of rheumatic fever who are having subcutaneous nodules. And they are always associated with severe carditis. To see subcutaneous nodule in a patient of rheumatic fever means that this child is most likely going to have severe carditis, because it is always associated with severe carditis. Although it occurs in only 10% of patients of rheumatic fever, but if present, it is an indication that this child might develop severe carditis. So these are the 5 major clinical features of rheumatic fever. If you want to remember it with a mnemonic, that is CPCS. Blood CP is usual investigation done in the wards to identify any infection, and blood CS is a blood culture and sensitivity test, is usually performed in a patient who is febrile. So you can write down CPCS in a descending order, and you can write that C is for carditis, P is for polyarthritis, and another C is for chorea, and over here is CES. If you incorporate E in between C and S, E for erythema marginatum, and S is for subcutaneous nodules. So this is a mnemonic CPCS, and that will help you in remembering the 5 major features, that is carditis, polyarthritis, chorea, erythema marginatum, and subcutaneous nodules. Beside these major clinical features, there are certain minor clinical features. And what are those minor clinical features? Fever, low-grade fever. Second, arthralgia, That is just patient is complaining of pain in the joints, but when you examine that those joints, there is no redness, there is no swelling, and just a patient is complaining of pain. So you say it's arthralgia, but if there is redness, swelling, tenderness, then that indicates it's arthritis. So the minor features are fever, low-grade fever, arthralgia, pallor means low HB, low hemoglobin, anorexia means the appetite is decreased, and loss of weight. So these are the minor features of rheumatic fever. That is fever, low grade, arthralgia, pallor, anorexia, and loss of weight. Now to the laboratory findings. They are non-capable of diagnosing acute rheumatic fever. So basically, rheumatic fever is a clinical diagnosis that you diagnose it on the clinical basis. Laboratory findings are just supportive. They are not capable of alone diagnosing rheumatic fever as rheumatic fever. They are just supportive in reaching to the diagnosis. Basically, rheumatic fever is a disease that is diagnosed clinically. And these laboratory findings can help eliminate other diseases. For example, if someone is considering rheumatoid arthritis, he can do a RA factor test. If someone is suspecting SLE as a cause of arthritis, he can do the anti-nuclear antibodies test. So these sort of tests can be done to eliminate the other diseases on the differential diagnosis list. And primarily, it's a, as I have mentioned earlier, is a clinical diagnosis. And the help of laboratory finding is that it helps in monitoring the inflammatory process. Usually in these patients of rheumatic fever, the ESR is raised. So we monitor the erythrocyte sedimentation rate ESR. And if it is gradually decreasing over a period of time, that will help us in noting that the child is gradually improving. And the other advantage of laboratory finding is that you can do the echocardiography, and that will tell you about the progress of the heart after the acute attack of rheumatic fever, that whether the lesion that was present, for example, mitral incompetence that has developed in the early phase of rheumatic carditis, might be the child could have recovered from that. So the echocardiography is a useful investigation to follow that whether the rheumatic fever that has caused damage to the heart was a transient damage or a permanent damage. So to evaluate the extent of cardiac involvement, echocardiography is one of the investigation that is done. The laboratory findings that are done is ESR, erythrocyte sedimentation rate. Second is, it is usually elevated. Second is anemia. Hemoglobin will be low. Leukocytosis, that is WBC count, will be increased. And there will be elevated C-reactive protein. And if you do the ASO titer, anti-streptolysin O titer, it will be more than 200 TOTS unit. And anti-DNase B test, if you do, it will be positive. And if you do the throat culture of such sort of children in which you are suspecting rheumatic fever, you may get a growth of group A beta hemolytic streptococci. And if you do the ECG of a child who is suffering from rheumatic fever, you may see prolonged PR interval in the ECG. And if you do the echo, it will indicate valve edema, it will indicate mitral regurgitation, it may indicate left atrium and left ventricular dilatation, it may indicate pericardial effusion if it is there, and it will tell us about whether the contractility of the heart is okay or it is decreased. So the laboratory findings that are done in patients with the rheumatic fever, I repeat once again, that the ESR will be raised, there will be anemia, there will be leukocytosis, C-reactive protein will be elevated, ASO titer will be elevated, anti-DNase B test will be positive. If you do the throat culture, you may get a growth of group A beta hemolytic streptococci. If you do the ECG, you can get the prolonged PR interval, and if you do the echo, that will tell you about the condition of the heart. Now the diagnosis, as we have just mentioned, that the investigations are only the supportive things. Basically, rheumatic fever is a clinical diagnosis. no single diagnostic test or a specific laboratory test is available for diagnosis of rheumatic fever. So basically, you have to rely on modified Jones criteria. This criteria guides you that what are the parameters, what are the things that you will be noting while assessing someone for rheumatic fever. And if the child fulfills that criteria, then you can label that child as having rheumatic fever. Now, the Jones criteria for guidance in the diagnosis of rheumatic fever. As you can see in this chart, there are major manifestations as we had just discussed earlier: carditis, polyarthritis, chorea, erythema marginatum, and subcutaneous nodules. These are the 5 major manifestations. And then you have the minor manifestations. They can be further subdivided into clinical as well as laboratory. The clinical minor manifestations are previous rheumatic fever. So if we get a history that this child has had a history of rheumatic fever, for example, two years back also, that is one of the clinical diagnosis, that previous history of rheumatic fever or rheumatic heart disease. And the arthralgia and the fever. So if someone gives you the history of fever, of arthralgia, of previous rheumatic fever or rheumatic heart disease, these are the clinical minor manifestations. And laboratory wise, you look for acute phase reactants. What are those acute phase reactants? Erythrocyte sedimentation rate, ESR in short, that will be increased, and C reactive protein, that will also be increased, and there will be leukocytosis, that is the WBC count will be increased. And if you do the ECG, there will be prolonged PR interval. So these are the minor manifestations. And then there are some certain supporting evidence of streptococcal infection. There are certain tests that need to be done. One is the increased titer of anti-streptococcal antibodies, ASO. As it's short, it is called ASO, anti-streptococcal antibodies. So if you see the ASO titer, that will be increased in patients with rheumatic fever. And if you do the throat culture, you will get it positive for group A beta hemolytic streptococci. And the third point is recent scarlet, history of recent scarlet fever. So for the supporting evidence of streptococcal infection, you need a raised ASO titer, you need a throat culture that's showing you growth of group A beta hemolytic streptococci, and a history of recent scarlet fever. So these are the supporting evidence of streptococcal infection. Now the guideline is how to diagnose rheumatic fever. The presence of 2 major criteria or of 1 major and 2 minor criteria indicates a high probability of acute rheumatic fever if supported by evidence of group A streptococcal infection. So how you diagnose rheumatic fever on the basis of Jones criteria? You need 2 major criteria, or if 2 major criteria are not available, then the second option would be, okay, if the patient is having 1 major criteria that we have already mentioned, what are major criteria, and out of those minor manifestations, 2 minor criteria are present in the child, and there is supporting evidence of streptococcal infection is present in the form of raised ASO titer or throat swab culture, which is positive for group A streptococcus, or recent scarlet fever. Any one of them, if it is present, that will be supporting evidence of group A streptococcal infection. So how you diagnose rheumatic fever? For that, you need to have either 2 major manifestations and supporting evidence of streptococcal infection. If that is there, that is enough to diagnose rheumatic fever. Or if supposing 2 major manifestations are not there, only 1 major manifestation is there. So for that purpose, you need to have 1 major manifestation and 2 minor criteria plus recent evidence of streptococcal infection. So if the patient is having 1 major and 2 minor criteria plus supporting evidence of streptococcal infection, that will be confirmed as a case of most likely rheumatic fever. Or the patient is to start with have 2 major manifestation present and there is supporting evidence of streptococcal infection, that is enough to diagnose that child as having rheumatic fever. So this is Jones criteria that tells you that how you are going to diagnose rheumatic fever. Now it's time to learn about the treatment. that, okay, fine, we know that this is a disease which is a sequelae of group A beta hemolytic streptococcal sore throat, and it may manifest as carditis, arthritis, chorea, erythema marginatum, subcutaneous nodules, and the minor manifestations. There could be previous history of rheumatic fever or rheumatic heart disease or arthralgia or fever, and the laboratory investigations, you can have leukocytosis and increased CRP level, and these are the manifestations. If we have this clinical knowledge and we have diagnosed that, yes, this is most likely a patient of rheumatic fever. Why? Because this patient is fulfilling the Jones criteria. This patient is having one major criteria, two minor criteria, and recent evidence of streptococcal infection is also there. So now you have made up your mind that yes, this is most likely a case of rheumatic fever. Now let's start the treatment. So the step one is the primary prevention. What is primary prevention? Eradication of streptococci. How you eradicate streptococci? By giving course of antibiotic. Then the second step is anti-inflammatory treatment, that the patient is having inflammation of the joints, inflammation of the heart valves. So you need to give anti-inflammatory treatment so that the patient gets symptomatically better. And then step three is the supportive management and management of complications. For example, if the patient is not taking diet properly, you take care of the diet of the child. The patient is having pain, you give the pain reliever for the pain management. If the patient is having some heart issues, you give bed rest to the patient, and you give medications to improve the working of the heart. And step four is the secondary prevention, meaning that prevention of recurrent attacks, because it has been seen that with the recurrent attacks, every time the recurrent attack takes place, there is a chance of further damage to the heart. So if someone has developed rheumatic fever once, we would not like to have the second recurrent attack of rheumatic fever in that child, because we know that with every recurrent attack of rheumatic fever in that child, the chances of damage to the heart will get further increased. So prevent the child from further damage. The step four is secondary prevention, that we don't want the child to have recurrent attacks. For that, we have to put the child on prophylactic therapy so that the child should not get the second attack of rheumatic fever. Now, the step one. Step one is the primary prevention of rheumatic fever, in which you treat the streptococcal tonsillopharyngitis. And the drug that you used is benzathine penicillin G. It's 600,000 units of intramuscularly is given once to a child whose weight is up to 27 kg. And if the weight of the child is more than 27 kg, that child requires 12 lakh international unit of benzathine penicillin G intramuscularly, and it's a single injection that is given, and that will treat the streptococcal tonsillopharyngitis. But for example, if a child is not willing to get the intramuscular injection and the parents insist that please give some syrup because my child is not going to tolerate the intramuscular injection, so the option is you can give penicillin V syrup, which is containing phenoxymethyl-penicillin in it, and the dose for children is 250 milligram 2 to 3 times daily orally for 10 days. And if the child is in adolescent age group and adults, you give 500 milligram of phenoxymethyl-penicillin 2 to 3 times daily for 10 days. So this is an option for a person who does not want to get the intramuscular injection. And for those persons who are diagnosed as rheumatic fever, but there is a family history that there is a hypersensitivity to penicillin, and then the individual is allergic to penicillin. In that case, what is the recommendation? In that case, the recommendation is that if someone is allergic to penicillin, naturally you are not going to give penicillin to that child, and you will give instead erythromycin estolate. Erythromycin estolate is a medicine that you give with the dose of 20 to 40 mg per kg per day in 2 to 4 times in divided doses daily orally for 10 days. Another option is if erythromycin is not available, you can give ethyl succinate 40 mg per kg per day and 2 to 4 times daily orally for 10 days. So there are two options for those who are allergic to penicillin. Either you give erythromycin 20 to 40 mg per kg per day in 2 to 4 divided doses for 10 days, or you give ethyl succinate 40 mg per kg per day in 2 to 4 divided doses. Now the step 2 is the anti-inflammatory treatment. For that, if the patient presents to you with only arthritis, the treatment is you give aspirin 75 to 100 milligram per kilogram per day. You give as 4 divided doses for 6 weeks. And the idea is to attain a blood level of 20 to 30 milligram per deciliter. So, for example, if the child weight is 20 kg and you want to give the dose of 100 mg per kg, so that will become 2000 milligram of aspirin. One tablet of aspirin is of 300 milligram. So, the total dose will be 7 tablets approximately. So, you will advise to take 2 tablets in the morning, 2 tablets in the evening, 2 tablets. 2 tablets in the morning, 2 tablets in the lunchtime, 2 tablets in the evening, and 1 tablet in the night, so that 6 hourly you will distribute those 7 tablets in 4 divided doses, and you continue it for 6 weeks. This is the treatment if the child is having only arthritis. But if the child is having rheumatic fever, is having carditis, then what you have to do, you have to start with the first prednisolone. The dose is 2 to 2.5 mg per kg per day. You give it as 2 divided doses for 2 weeks. Then after 2 weeks, you taper the dose gradually, and you finish the steroid dose in the next 2 weeks. And when you started tapering the dose of steroid, you add aspirin with a dose of 75 mg per kg per day during that 2 weeks of tapering of steroid. And after 2 weeks, when the steroids are stopped, you continue alone aspirin with a dose of 100 mg per kg per day for another 4 weeks. Now the step 3 is the supportive management and management of complications. In this, you advise the family to have the child to have a bed rest, and if there is congestive cardiac failure, you prescribe digitalis and diuretics. And if suppose rheumatic fever child is having chorea, you can control it by giving diazepam or haloperidol. And you also give rest to the joints, and supportive splinting is done to minimize the pain. Then the step 4 is secondary prevention of rheumatic fever. And for that, what you do, you give benzathine penicillin G 12 lakh international unit every 4 weeks intramuscularly, or you can give penicillin V 250 milligram twice daily orally, or you can give sulfadiazine 0.5 grams once daily for patients up to 27 kg, or 1 gram once daily for patients more than 27 kg. And for individuals who are allergic to penicillin and sulfadiazine, you can give erythromycin 250 milligram twice daily orally. In high-risk situation, you have to administer every 3 weeks, especially in patients who are having rheumatic heart disease. Recommendation is you can give in this benzathine penicillin G injection every 3 weeks. Now the prognosis. The rheumatic fever can occur whenever the individual experience new group A beta hemolytic streptococcal infection, if not on prophylactic medicine. So it is very important that one should give prophylactic medicine to avoid the child to have a second attack of rheumatic fever. There is good prognosis for older age group, and if no carditis during the initial attack. So if when the patient first had rheumatic fever attack, if in that child at that time the age was supposed to say older age, 10 years, 12 years, and the chances are that will be good prognosis, and especially good prognosis is seen in those patients of rheumatic fever where there is only arthritis as the major complication present, and there was no carditis during the initial attack. So those children who are having only arthritis during the first attack of rheumatic fever, not involving the heart, they have very good prognosis. Bad prognosis is for younger children and those with carditis with valvular lesions. Thank you. I thank you very much for your attention. Now, if you have any questions, you can ask. लेक्चर हो गया, मैंने पूछा कोई सवाल पूछना तो पूछ लें. हो गया. क्या सवाल है? G. The one question that is asked is that Sir, how this infection induces anemia in the child? It is sort of, you can say that as the patient develops rheumatic carditis, the patient develops rheumatic carditis that may lead to cardiac failure. And in this cardiac failure situation, there is retention of fluid. And because of the retention of salt and water in the body, there is decrease in the hemoglobin content of the blood. So it's a dilutional sort of anemia that is usually seen. Another question that is asked was, how much time does it take for symptoms to develop after streptococcal sore throat? So it may develop after 1 week or 2 week or 3 week or after 5 weeks. And sometimes in patients with rheumatic chorea, it may take 6 months after the rheumatic fever that the child presents to you with chorea. And that is rheumatic fever. Another question that was asked, sir, are we supposed to learn all these doses of drugs? The answer is no. You are not supposed to remember the doses of the drugs. Only what should know that rheumatic fever is a disease caused as a sequelae of group A beta hemolytic streptococcal infection, and it affects the heart, the joints, and the subcutaneous. Major manifestations are carditis, polyarthritis, chorea, erythema marginatum, subcutaneous nodule, and the minor manifestations are fever, arthralgia, prolonged PR interval. And for diagnosing rheumatic fever, we have to follow the Jones criteria, which tells you that either you have to have two major criteria and recent evidence of a streptococcal infection, or you should have one major and two minor criteria plus recent evidence of a streptococcal infection to diagnose. And there is no need of remembering the dosage. And the difference between arthralgia and arthritis, arthralgia is the subjective feeling that the patient will complain to you that I'm having pain in my right knee joint, for example. But if you examine the joint, there is no redness, there is no swelling, there is no tenderness, there is no increased temperature over the joint. So you can say that you are having arthralgia, just pain in the joint. You are not having arthritis, because in actual rheumatic arthritis, what you see, for example, if there is rheumatic arthritis of right knee joint, you will be seeing a right knee joint which is swollen, which is red, which is having elevated temperature over the joint, and that will be exquisitively tender. Just touch it and the patient will cry. Uh, as far as one question was, uh, repeat the last slide. And the last slide was regarding the prognosis of the illness, that if the patient develops rheumatic fever at an older age and there is only arthritis, the chances are the prognosis will be very good. But if a child develops, say, at a younger age, 7-8 years, rheumatic fever, and there is in the initial attack there is a rheumatic arthritis along with carditis was there, then the prognosis of that child will be bad. And another question that was asked is, sir, can you repeat step 4? Um, uh, Step 4 was exactly it was regarding the prophylaxis therapy, meaning once you have treated a patient of rheumatic fever, the patient got better. What we want that the child should not get an infection second time. There should be no recurrence of streptococcal sore throat, because every time there is recurrence of streptococcal sore throat, there is a chance that it will further damage the heart. So the step 4 tells you that how to prevent a child from developing recurrent attack of rheumatic fever. For that, guideline is that you should give injection Panadior LA, that is 12 lakh international unit intramuscularly every 4 weeks. And it depends for how long. If the patient is having only arthritis and there is no carditis, the recommendation is that you give this monthly injection after every 4 weeks till the age of 5 years, or at least for 5 years, or till the child reaches the age of 21 years, whichever is longer, whichever duration is longer. Meaning, to make it short, up to the age of 21 years you have to give to a child every 4 weeks the intramuscular injection to prevent the recurrence. But if someone is having rheumatic carditis, that in that case one has to give in a Pakistani setup where there is overcrowding, poverty, socioeconomic condition is not good, and there are high likelihood there of recurrent streptococcal infection. Recommendation is that you have to give for life. Sir, what does this mean that if arthritis does not respond to aspirin, the diagnosis is in doubt? Because it is noted that in children who are having rheumatic fever causing arthritis, they respond dramatically to the aspirin. Just you give a dose of aspirin to the child, and after 6 hours, the family will be very happy that the child pain has, there is no pain that was there for so many days. Just by giving, डॉक्टर साहब अल्लाह ने आपके हाथ में बड़ी शिफा दी है, एक गोली से ही आराम आ गया है. So if the patient has got better by just giving one tablet or two tablet of aspirin as a first dose, that is a very high likelihood that this patient is having rheumatic fever, because it is a known fact that the children with rheumatic fever respond dramatically to the aspirin as compared to children with rheumatoid arthritis, in which if you give aspirin, they will respond, but not that much fast response you will notice in rheumatoid arthritis as you will see in patients with rheumatic fever. Another question that is asked is rheumatic heart disease a manifestation of rheumatic fever, or is it different? It is a manifestation of rheumatic fever. Once a child develops rheumatic fever, if a child is lucky, only he develops arthritis and no other complication, then he or she might not develop rheumatic heart disease. But if on the first occasion the child is, for example, the child was younger age group, and first time when the child had rheumatic fever, along with the rheumatic fever, arthritis, the patient was also having carditis, and when you follow the patient, the carditis symptoms persisted, and the child then convert into a rheumatic heart disease patient. So rheumatic heart disease is a complication of rheumatic fever. Yes, sir. One question is, sir, step 4 is lifelong. Yes, in Pakistani setup, if someone is having rheumatic fever along with carditis or cardiac failure, involvement of heart is there, then recommendation is yes, you have to give it for life. But if the child is having rheumatic fever only arthritis, then the recommendation that, as I have already mentioned, that you have to give it for 5 years or till the child reaches the age of 21 years, whichever is longer. Another question is asked, how to make the diagnosis if the throat culture is negative? Both in book it says, because in book it says that in only 10 to 25% throat culture is positive. Yes, it's a good question. I have just mentioned that for recent evidence of streptococcal infection, there are 3 things. If you get out of those 3 things only one, that is sufficient to fulfill the Jones criteria. Supposing if you get the throat culture positive for group A epidemiology streptococci, that is enough to fulfill the evidence of recent evidence of streptococcal infection. But supposing you don't get the throat culture, but you get the ASO titer that is significantly increased, more than 200 international unit, that is sufficient as an indication of recent history of streptococcal infection. So if you have a raised ASO titer along with so say 2 major criteria, or 1 major and 2 minor criteria along with raised ASO titer, although throat swab is negative, fine, you can diagnose rheumatic fever. So for diagnosing rheumatic fever, there is binding that the child must be having some evidence of recent evidence of streptococcal infection, either in the form of raised ASOT, either in the form of throat culture that is positive, or either in the form of history of recent scarlet fever. Sir, what is epidemiology? Is rheumatic fever is common in Pakistan or not? It was very common when in our student days, but nowadays I am seeing less cases of rheumatic fever as I used to see when I was a student or my residency time. Might be because of some improved socioeconomic condition, might be that the patient is getting the proper treatment for streptococcal sore throat, so that the child is not developing rheumatic fever. So although rheumatic fever is still there, but the incidence is much less as compared to in the past. Okay, thank you very much. God bless you. Allah Hafiz. Finish.